I want to introduce everybody and turn it over to the panel. First, we have Janet Meyer, the CEO of HealthShare, Jeff Heatherington, CEO of FamilyCare, Greg Van Pelt, the Executive Director, President, CEO of the Oregon Health Leadership Council, Imelda Dacones from Northwest Permanente. Appreciate all of you guys being here, and our esteemed guest and friend, former Governor John Kitzhaber. We're giving you the reins, the keys to the car, sir. It is all yours. Don't screw it up.
It's great to be the moderator here, right? So I have 4 areas I'd like to explore. This has been kind of a challenging year for the healthcare sector, both at the state level and at the national level. So let's start at the state level. Oregon has had this remarkably collaborative, bipartisan approach to healthcare reform for 30 years in Oregon. The Oregon Health Plan, the bill that created that with its prioritization, passed 30-0 in the Senate and 57-3 in the House. And in 2012, if you recall, a bill that created the coordinated care organizations in a legislature split and in a House split 30-30 between Republicans and Democrats, passed by a vote of 53-7 until 2017. And this last session, in my view, is one of the more partisan or divisive sessions in recent memory, particularly when it came to the issue of filling the hole in the Medicaid budget. So I guess the question is, how do you think we moved from this bipartisan approach to health policy to what we saw in 2017? And what do we need to do to build a common agenda for healthcare going forward into an uncertain future? So let me start with Jeff, and then we'll just see what other people have to say.
Well, starting with the 2017, I'd say 2 things. First of all, the disagreement among the parties was primarily on the way the financing was done. I think we still maintain the bipartisan nature of support for the Oregon Health Plan as it was originally conceived and as it's gone forward. And that's the good part. Now, they got to somehow get together on the funding, but I don't know that there's anybody I could name in either the House or the Senate in either party that actually isn't in full support of the Oregon Health Plan now. So I think that's the good part. Money is always the hard part, and Greg can solve that.
Well, my observation, and I would like to have Greg and the other folks who were, I know, engaged in that, was that I don't doubt that people support the concept of the Oregon Health Plan, but moving it from concept to keeping it going on the ground with all the wheels on requires some pretty difficult political decisions, and in my view, a different tone to the conversations between the various parties, which I thought seemed to be lacking. Greg?
Yeah. We knew, I think, when we started the coordinated care concept, and we knew, as we talked about social determinants, we knew kind of jumping this curve was not going to be easy. And it is often then, this was kind of the tension point. It was, when you look back, it wasn't easy setting up the CCOs. It wasn't easy getting them off the ground, but this is where we start to test the model when things get hard, and they're going to get harder. And I think the lesson learned out of this, we've got to start earlier, and we've got to make the conversation more than a math problem. And I think that's what it got down to. We waited too long. We knew it was coming, and towards the end, we had to solve a very difficult math problem in a very short period of time. So in some respects, we went to the most convenient solutions, and I just think we have to start sooner. We have to agree on principles. That's the other thing that we failed to do this time that we did earlier, is to start with principles as opposed to, again, just jumping to the math.
Okay. I agree. I'm sorry, Imelda, go ahead. I think there were some rough spots at the beginning of the session in terms of the revenue and the expense reduction that we needed to do. But in the end, the parties did come together for a solution that buys us some time. I agree with Greg that we need to start now because it only bought us a small amount of time, the budget solution and the expense reductions, and it's going to get harder. But I think, there were some stumbles and there was some unfortunate end of session activity, particularly aimed at the Hospital Association. But by and large, parties came together to solve that problem so we could keep the program moving forward.
Right. I mean, I really love the alignment and how this state is nation leading in that work, and we need to build on that. And to your point about just diving into the math right away, what are those principles that we can agree on and work around that? So that's number one. Number two is there's a lot of conversation about how we afford coverage, how we pay for the Oregon Health Plan. I think the other conversation needs to be around how do we shape, influence, and also develop a care delivery system together that provides high quality, affordable health care.
So that's a good segue into the total cost of care issue. But let me just say before we move on that this is the end of 2017, and we know we're going to have to revisit all of this in 2019, so maybe tomorrow would be a good day to start.
Yes. Yeah.
So we know that the cost of healthcare is really the elephant in the room. And if you stop to think about it, healthcare is the only economic sector that produces goods and services that most of its customers can't afford, but all of whom will need at some point, often as a matter of life and death. So the only way a market works under those circumstances is if it's heavily subsidized, which is why the healthcare debate for the past 50 years has really been focused on how do we pay for those subsidies, either through public or private insurance. So we've demonstrated with our coordinated care model, at least initially, that we can reduce the cost of care without sacrificing access and quality. So how do we continue to move that model forward? How do we begin to shift the debate from how do we make health insurance more affordable to how do we make healthcare more affordable? And what are the lessons from our coordinated care organizations that we can begin to move out into the private commercial market? And I think I'll start with Greg on that one.
Yeah, to your point, John, about total cost of care, and I think we've also learned this, that if we look at a particular segment or try to impose artificial restraints on a particular segment, it pops up over here. Healthcare is still about benefits, eligibility, and cost per unit of service. And any time you tinker with one, you have to expect that utilization might go up, price might go up, because each organization in some respects has to pursue its enlightened self-interest if you look at each segment within the total cost of care. So we again have the structure with the CCOs, and I think and we're starting to see that in Medicare and a little bit in commercial, where we have to look more at the community total cost of care. And I know QCore, now Health Insights, is doing some of that work. The conversation has started, but if we use that information just to find the villain, so to speak, we're going to find it pop up again someplace else. And I understand our argument about the pharmaceuticals. I understand the argument about hospital costs. But if we just use this information to go after one part of the total cost, it's going to pop up somewhere else.
Who else?
No, I agree. You cannot, it's a complicated and complex problem, and if you just attack it in one sector, you will not succeed. What I can say is that what I'm longing for is the physician voice in the solutioning to the healthcare costs, because if you believe that 30 to 50% of what we do in healthcare, whether that be unnecessary testing, unnecessary services, ridiculous administrative costs, and the like, what I can change as a physician, I totally have control over. I can follow the guidelines and not order unnecessary testing, and I can follow the guidelines and prescribe drugs when they're needed, not because I think that's what the patient is expecting. So be the change you want to see, honestly, for the physicians in the room and for America and in the state. It's really about when do we start talking about what is waste in the system that you and I have control over, frankly. And we have the most intimate relationship of all. If you think about the payers and everyone else involved in healthcare, I am closest to my patient. So I feel the need, I have the need to advocate for that.
Janet?
I think I would add two thoughts, kind of going off of what she was just saying. I think there is a lot of waste in the system, a lot of unnecessary treatment and duplication in testing and diagnostics. And that's not a Medicaid problem or a Medicare problem or a commercial problem, that's the system's problem. And I think if we want to really get serious about it, we need to start collaboratively designing a health information exchange that is actually useful and can be used. And I think the Health Leadership Council teaming with the OHA on the new HIT Commons is a great start for us to start thinking about how do we get the information where it's needed, when it's needed, so that we can reduce some of this unnecessary care in our system. The other point I would want to make is we have a tremendous burden in Medicaid, but it's a society burden as well, in mental health and addictions, and particularly the untreated complications from mental health and addictions, which are paid for in the physical health system. We've underfunded the mental health specialty system of care for mental health and addictions for decades. And until we really start moving the money where the problem is, I think we're going to have a hard time catching up with that train. So I would also advocate rethinking how we fund mental health and addictions treatment.
So how do we have that conversation? Because you can argue with me. I think one of the reasons it's so hard to reform the healthcare system is because we keep paying for it.
Right.
Right, and if you continue to fund the status quo, there's not much of an incentive to change it. And the incentive for the coordinated care organizations was a $1.2 billion hole in the Medicaid budget that would have translated into a 39% provider cut rate if we hadn't done something about it, right? So I think the hard cost of care growth cap at 3.4% is really what created the energy to begin to change the system. So do you think we can reform the system without, so we're not talking about reducing the amount of care we're currently spending, we're talking about reducing the rate of its growth to something that's actually sustainable. So do you think you can have that conversation without some kind of downward pressure in terms of a growth cap?
My answer to that would be, I don't think you can. And I try to shy away, it's a strange word for me to use, but I try to shy away from...
You mean shy is the word? Is that
that's the word.
Let's check.
From the discussions to say, with all due respect, that it's a complex problem. Yes, healthcare is very complex, but it's just like triaging a patient. If you got a patient with an open artery, you don't sit and talk about should we fix the wrist first. And we've got two broken arteries, pharmaceuticals and to some extent hospitals. If you don't fix those two, the rest of the discussion is going to be very academic. And then you can go down, and I certainly agree with the hassle that physicians have to go through to get to their patient. I think that's a big problem. The bureaucracy is a big problem. But we've got to have the conversation of what we do with pharmaceuticals. Those, pharmaceuticals, people don't know what the rate of increase is almost 16% a year. And that started right after the ACA. So it's a problem there. You can address that, and you have to address the rest of the system. But we can't say, well, we got to look at the whole system and talk about it for the next 5 years.
So let's put that on our list for tomorrow.
Yeah.
Right. So just one last thought on it, and then we'll talk a little bit about what's going on or not going on in Congress. So if you believe that the downward pressure from the $1.2 billion revenue shortfall was what created the impetus really to get serious and look at things in a different way, I would argue that we're facing almost the same circumstances today, except the downward pressure in the system is not coming from a recession, it's coming from proposed congressional action. Whether the replace and repeal ultimately passes this year or next year, the problem isn't going to go away because Medicare and Medicaid are now the major driver of our national debt, which is close to $20 trillion. And you probably read that the president cut a deal with the Democratic leadership to lift the debt limit a little bit until December to accommodate relief for Hurricane Harvey. But at some point, you're going to have to get your arms around Medicare and Medicaid just as a matter of national security and fiscal stability. So the question to me is whether we're going to get there first and have that conversation, or whether we're going to let someone else do it for us. And I think to your point, I think people in the system are much better qualified to figure out how to reduce that cost while maintaining quality than the United States Congress. So
Yes.
can you just maybe comment on that a little bit? I think it's coming, and the question is whether we want to do it ourselves or have it done to us.
Speaking as a physician, I would rather do it than be told. I mean, as an ED physician, you're not going to have a payer tell you when and where not to put a chest tube. But as the collective physicians, they're the subject matter experts in care. What really is waste and what is not waste? And until we change ourselves, we can keep talking about how we pay for this. How are we going to pay for this? 20% GDP by 2025. How are we going to pay for this? The conversation at some point should shift to or include what do we do differently so that it is affordable, so that it is accessible to all of us in the room and to our grandchildren yet to come. Because even now, many of us in the room, we know friends, I know you have friends and family members who struggle. Yes, I have insurance, but to get that copay, $150 copay for that visit, or to pay that $200 prescription per month. So I would love to have that in the debate, and to your point, have the subject matter experts be consulted or be part of the discussion, be part of the table, and not just continue to have insurance people and people who have never prescribed a drug be talking about pharma and utilization of unnecessary testing where they've never ordered it and cannot even conceive.
So Howard, just to push this a little further, so if, I think we all know that the other elephant in the room is pharmaceutical costs. I mean, they're outside the cap, they're not capitated, and neither are hospital costs to some extent. So if we're going to start early and have a conversation that's going to lead to a unified common approach to health policy in the 2019 session, how do we talk about hospital costs? How do we talk about pharmaceutical costs? What does that table look like and who's sitting at it?
A couple things. To both Imelda's point, and even going back to the start of the Oregon Health Plan. It's like and looking at the line, what can we afford, what can we do, what's the evidence as to where the greatest return on investment is? Because even in markets where you neutralize, say, the hospital costs, you still have a tremendous variation in cost and quality. And to Imelda's point, even in those markets, we know there's waste. And how do we get information to people so they can make the right decisions? And we are going to have to make some difficult decisions. Even in the ACA, when we eliminated the $2 million benefit limit, well, that was kind of a signal to the pharmaceutical companies, well, this is the gravy train. We can charge whatever we want, as much as we want, because there's no limit on what the system will pay. And we've paid it. So at some point in time, we've got to have that. I do agree, we do worry about the revenue, but we've also got to be able to say, what aren't we going to do? And I'm not sure that healthcare, I think, Governor, you mentioned this, I don't know that the market alone can solely solve this. I don't know that it's price controls, because I've seen that where then it'll just pop up someplace else. But how do we use, I'm going to say, the wisdom of our frontline providers to say, that isn't helpful, and we're not going to use it. We're not going to do it.
Right.
So if you recall, when we originally did the health plan, the idea of the priority list was to create a more rational way to design a benefit. So, for example, if you wanted in vitro fertilization, instead of passing an insurance mandate, you had to justify that service was more important than everything else above it on the list. What would you think of adding specialty drugs to that process? So, as you know, there was a class action suit in Washington State that forced the health authority to provide Hep C drugs for anyone who was infected, not just people who had liver damage, which I think tripled their drug budget from something like $1 billion to $3 billion. Right. And of course, that squeezes out early learning, prenatal care, a whole host of other things. What would you think of having that conversation, since we already have the list? So if you want to mandate hepatitis C drugs, you got to make the case that that's more important than all the things that are going to get squeezed off the benefit.
Well,
Jeff?
that's been proposed several times, and it doesn't seem to find much truck with the legislator. with the legislature yet, but I think it's a great idea, and I think we also need to take a look at how we fund and where we fund behavioral health in that process also. Frankly, I think behavioral health needs more support, but I would go beyond the specialty drugs. I'd go to all of them, because we know, some of the old line drugs, which, well, they were pennies on the dollar, that they may have gone up to $100 a pill now, but we know the old line drugs sometimes work just as well as the brand new drugs. And the prioritized list, I think, could solve some of that.
Well, I think the takeaway, at least, I don't know if there's any legislators in the room, but the whole idea was to force the legislature to be accountable, not just for what it paid for, but also what it didn't pay for.
Right.
And we're the only state in the nation that at least has the framework to have a more rational discussion about that. And that's not painting people with white hats or black hats. It's just simply saying that we have finite resources, and how do we spend that in a way, particularly in the Medicaid budget, to maximize the health across the population.
Exactly.
So let's go to the federal stage. So since January, we have had 3 efforts to replace and repeal the Affordable Care Act. We've had the American Health Care Act out of the House. We've had the Better Care Reconciliation Act out of the Senate, and most recently the Graham-Cassidy proposal. And what those all have in common is a dramatic reduction in federal spending on Medicaid by simply cutting payments to the state, which is a huge cost shift and would result in dramatic increase in enrollment. So we know that this is an unfulfilled campaign promise for the Republicans. We've got the midterm elections coming up, and I think it's fair to say that this is coming back after January in some form, given the fact that we have dodged the bullet by just 2 or 3 votes in the Senate. Do you think it's time for those who have opposed replace and repeal, including the Democrats, to put forward an alternative, instead of just saying no, put forward an alternative that addresses the one issue that I think is legitimate in the Republican argument, and that's that the Medicaid budget is ultimately unsustainable?
I think that's good offense and defense, and that's what's been missing, is just saying no and not having an alternative to counter these proposals to date. What do we stand for? If you're saying no to what the Republicans are proposing, let's say, well, we're going to iterate on what was missing from the Affordable Care Act to begin with, rather than throwing out the whole thing. And that's what I see has been missing.
You know this better than anybody. Incrementalism is how you get policy change done.
Right.
And this whole idea of a giant repeal and replace is just not tenable. And I think the more times they keep they're pounding on the wall expecting it to turn into a door, and it's not going to. I think one thing we've done in the Medicaid business, which was good in the beginning, was to destigmatize Medicaid. We branded it as other things. So we have Badger Care, we have the Oregon Health Plan, and a lot of the constituents who are supporting these repeal and replace don't even understand that they have Medicaid, because we've successfully rebranded it.
Right.
So they're actually working on. So I think we could do a little better job as policy leaders in talking about what Medicaid really means. The other thing I would point out is the Affordable Care Act is just a small part of Medicaid spending. It doesn't talk about long-term care costs, which is by far the larger component. So I think we need to be a little more honest about what we would be saving and what we wouldn't be saving.
So just in case Jim Carlson's in the room, what would you think in terms of the conversation we're going to have? We have the medical portion of the dual eligibles in our capitation rate, but the long-term care part is outside. So what would you think about having the conversation to bring that in and subject it to the same kind of management protocols that we have done with the rest of the Medicaid budget? Third rail.
That's up to you guys.
Yeah.
Right,
Can I consult with my staff before?
I was going to check my tweets.
Yeah, I do, historically, again, going back to the social contract, the social capital, to me it's best to lead. And even a proposal, when I look at our own state, where the general funds have gone from about 22% of the budget supporting the Oregon Health Plan down to 7, it says to me we've got some work to do at home first. And I think this 19 budget, regardless what's happening at the federal level, we know there's going to be greater financial responsibility placed on the states. So let's get started and show people what, we have the infrastructure in place, we have the CCOs, we have the prioritization list, we have the engagement. Let's show people what we could do, whether it's either a spending limit or, we have knocked down, we have bent the cost curve. We're not moving quite fast enough. So it's great to make a proposal, but there's a part of me that says let's prove it to ourselves, then we can prove it to the rest of the country. Jeff?
There's, one of the things that when the whole ACA movement started, and I was doing some talking around the country about, what Oregon was doing and listening to what other states were doing. The other states in general are about 25 years behind Oregon. And when you start talking about what Oregon can do, I think one of the things that Oregon can do and should do is start advertising its model, because we know it works. It certainly works better than most of the fee-for-service programs in the other states. We also know that the prioritized list works. And that's something we could trademark and sell to the other states and maybe make a little money off of it. But, I'm mercenary in that regard. I think we could make good money off of it. But the bottom line is we can do, and we have done a good job in Oregon, but we've kept it all to ourselves. And you talk about leadership. I think we could do some leadership out to other states, talk to Washington, which has got a terrible access problem, talk to, California and some of those others, and really sell this as a product of we can, hate to do it like this, but we can do better, and Oregon can show you the way, show you the kinds of innovations we have done within each of the CCOs, and try and market that out, because if that starts to reduce the national pressure, it will certainly help us. The other comment I have to make, and you'd actually be a better one to talk back, we tend to think about Medicaid in a vacuum. Mm-hmm. And the bottom line is that there are a lot of other big pressures on the state budget. Mm-hmm. And I think, everybody talks about PERS in the bathroom, and they talk about Medicaid up front. And if we didn't have the PERS problem, we might have a lot more money to invest in our Medicaid, and we might not have the budget problems we have now. So it's not just, it's not all about us.
No, and I think actually, I'm interested in what you think about this, to broaden the conversation so that the common health policy agenda that we're trying to move in 2019 is not just driven by providers. So for example, and I think these are Janet's words, I think they're very elegant, Medicaid is also sort of the infrastructure for moving up the income ladder.
Yes.
A lot of these people are working, and this is what actually keeps them on the job. Mm-hmm. The debate over the minimum wage increase, if we don't do something about co-pays and deductibles, by the time we hit $15 an hour, it will all be gone. Or the fact that people, as they move up the minimum wage, actually begin to lose other social supports, and in some cases are worse off. So those are all issues that interface with the healthcare system, and perhaps we need to broaden that conversation to include the rest of the elements of what gives people the opportunity to actually succeed in our state.
Well, that somewhat brings in the comments about social determinants, which I don't like that word. I use the word community because I know who community is, and when you start talking about education, it's not social, it's the educational system. And environmental systems, it's the cities and counties, and housing is the counties. So I think if you start addressing those adequately, then what you do is you slow the flow into the healthcare system. Now that's a long-term conversation, but if we never start, we'll never get the flow down. And we know what the major problems are. We just haven't told those sections of society to fix them to help us lower the cost.
So actually, that was the fourth area I wanted to touch on. So that was a very nice segue. So I think we all recognize that that most of what affects our lifetime health status doesn't involve the formal medical system.
Yes.
We've all seen the social determinants pie chart. And I think there's a growing recognition among hospitals and coordinated care organizations that these are important investments to make. The big investment that was made up here in housing, I think, is a good example of that. But if you stand back and look at it, often these investments are not coordinated. They're not necessarily evidence-based or leveraged or long-term. Sometimes they don't directly and meaningfully engage the very populations that are facing the greatest health disparities. In many parts of the state, there's just simply not the capacity to make these kinds of investments. And I think, quite frankly, issues like housing or family stability or food security are not really core competencies of hospitals or coordinated care organizations. So let's talk a little bit about the idea of trying to create some kind of collaborative approach to funding these social determinants that leverages on a regional and statewide basis the impact that these would have on our state.
I think that's definitely something that the CCOs are recognizing at this point in our evolution, that we need to work together. We've been spending a lot of time working cross-sector. So working with the education system and working with community benefit organizations that serve our clients. And we also need to work across CCOs to share learnings and to, is there something we should all be focusing on and leaning into to really move the needle in the next few years. I think we've learned that. I think that one of the smartest parts of the waiver, or most intelligently designed parts of the waiver, was the performance metrics and the incentive metrics that they gave us. Because when you're trying to affect your developmental screening rate or your kids in foster care getting their assessments, you do start working with partners in new ways. You start looking at the system of care in new ways, and you start investing your money in new ways. And that's when we get to the long term, changing the trajectory of our clients' lives for the long term. Effective contraception is important because an unplanned pregnancy for a young woman is often a ticket to poverty. If she's not married, if she drops out of school, she can't work. So these are real intelligently designed metrics that are driving the CCOs to work in a space that we didn't think we would be working in a few years ago. I think it surprised a lot of us, but we haven't done a good job talking about it. And I think, honestly, the OHA doesn't even know all that the CCOs do, including working with our community benefit partners at our hospitals in very innovative investments. Each community, it's Coos Bay, Klamath Falls, everybody's doing this, but we're not sharing it, we're not talking about it, and we're still in this sort of head down, getting the work done mode. And I think, to Jeff's point, we need to pull ourselves up and talk about it, because it's a story to be told.
So if you look at the data for Oregonians on the ACEs, the Adverse Childhood Experiences Survey, 64% have one or more adverse childhood experience. And when you look at the OHA data on these children and become adults and report these, the higher number adverse childhood experiences, which are broken up between abuse, neglect, and family dysfunction, including housing and the food insecurity, the higher the number, the more the incidence of depression, addiction, diabetes, obesity, chronic lung disease. So social determinants of care, if you go further to the left and earlier in life when children, we support, Kaiser Permanente supports school-based programs. We've now taken it even further with our pilot experiment, what you might want to call it, with the Fabian Concordia University 3 to PhD program, where we embed not only the healthcare in the school, but also you have food. You supply the children with food that they take home and the family can share. You have the students from Concordia University literally cross the street and also embedded in the elementary school, working with the children, physical therapy students, teacher students, working embedded and affecting, impacting, influencing those food insecurity. They have wraparound services, social work. So that's where I believe, is the intervention, and this is the partnership. So it's the public school with healthcare system, with higher level of education, with it's that community that you speak of that, because that's where we live. We live in the community, not within the four walls of healthcare system. So I think those are the opportunities that we should learn from. The collaboration that we have with Unity.
Yeah.
I think what's going on in DC is helping us think more creatively and also really link arms and find those opportunities where we can say, you're my partner, we're going to solve this together for our children, for our communities. Heck with DC. So I'm excited for those. And I think there's more to come and learn, and Oregon is the place to be for that.
We've got about 2 minutes here. I'll just want to respond to that and give you each an opportunity to make your final comments. I think that the ACEs, I think that contrary to what we're being told by our current political leadership, the biggest threat to our country is not terrorism or our trade deficit with China. It's the fact that we have 60% of our kids are exposed at a very early age to one or more risk factors that can profoundly compromise their ability to succeed. And you can't protect those kids from those risk factors by building a wall. You can only protect them by building strong families and strong communities. And I think that the coordinated care organizations and this effort we've had in Oregon are more powerfully poised than any place in the country to recognize that, acknowledge it, and actually begin doing something about it. So, Janet?
Yes, I agree with you.
Right. Well, this is a first.
But do you agree
I
with
don't,
me?
I don't know how you can say
But do
it
you
any
agree with
stronger.
Janet? That's the real question.
But I think, taking off on what Janet said, that, if we start working outside our own bubble, and calling out the rest of the communities and saying, we need your help, and we can give you our help. We've got a great program with the Gladstone School District. It's very small, but the superintendent there found out about ACEs many years ago, started working with it. He's taking care of those kids from the day they're born because he knows he's going to get them when they're 6 and he's going to have them for 12 years. And so he's working on all the community determinants to make it work. If we could do that within all of our school districts, we'd be way ahead. And I think it's up to us to help lead it.
I would just, my final words would be to make the observation that it's been very difficult to work in healthcare in general with the disequilibrium in the Oregon Health Authority, with having so much turnover in leadership and so much talent that has left the agency. And we have a real opportunity here with the new administrator, and we're really hopeful that that agency is so important in so many ways. It's I think people underestimate the impact that agency has on our citizens' lives, and so the more support we can give the agency, and the more, I think that will also help the legislature get a little bit more comfort if they're feeling like they have the agency and working collaboratively with the legislature, so we can have a little bit more political will about some of these difficult conversations. So go Pat Allen.
Yeah.
Greg? Yeah, we've all worked in, knowing all of you, almost our entire careers building this infrastructure. Let's use it. Let's keep going. I think we do have this transition time that we do have to figure out. It might be a revenue question, but what we can't do is use the short-term pressure to kind of destroy the momentum that we're building. Right. So, but that takes discipline, and that takes using the tools and use them as opposed to give up on them. And in the meantime, let's get started on 1921 budget and figure out a funding mechanism that supports these efforts as opposed to causes everybody to go back into their foxhole and care about their own self-interest.
Thanks.
The way you reduce healthcare costs, the way you reduce hospital costs is you don't get hospitalized. We focus so much on rescue care, not enough on incremental care where health and wellness is emphasized. I would love to be out of a job as a physician because everybody in this room is so engaged. You're owning your health in America, and Americans are owning their health and wellness, and put me out of business. That would be an aspiration. But the way we reduce healthcare costs is we stay healthy and investing in our communities and our children so they grow up with wellness and health as it's just the way you live and live.
Well, I want to thank all of you for being here. I want to just give one closing thought to you. I think Pat Allen is a great choice for Health Authority. I think he's going to do, and his team, he brought basically sort of stripped the insurance division and brought everybody over to the Health Authority, so I don't know what's going to happen there. But it's a great team. What they're going to need, though, is they're going to need good policy input. They're going to need to know what it is they're supposed to be managing. And if we have 16 different voices on policy from 16 different coordinated care organizations, it's going to be pretty confusing. So I think the challenge is to develop that unified voice of what the policy should look like, what CCO 2.0 should look like, and how we address those issues that Greg brought up. DJ, back to you.
All right, let's give him a round of applause.
Thank you.